Hello, good evening, madam.
Good evening, sir.
Uh, so today is systemic bacteriology, madam.
Yes, sir. Part 2. Gram-positive bacteria, sir.
Yeah, please continue.
So once gram-positive and negative part will be over, I'll take MIC and MBC class.
Yeah, please, madam. Please.
Okay, sir. Can I proceed?
Yeah, madam, please proceed.
Okay. So hello everyone. Welcome to Tawhid Foundation for Allied Healthcare Sciences, Bangalore. Today's class is for BSc second year MLT student, Systemic Bacteriology Part 2, that is gram-positive bacteria. So gram-positive bacteria is a group of microorganisms of immense medical importance. Gram-positive bacteria are characterized by a thick peptidoglycan cell wall that retains the crystal violet stain in gram staining. They include clinically significant pathogens such as Staphylococcus, Streptococcus, Enterococcus, Bacillus, Clostridium, Corynebacterium, and Mycobacterium. So, studying them gram-positive is crucial because they cause a wide range of diseases from skin infections to life-threatening sepsis, meningitis, and tuberculosis. Many procedure toxins that contribute to disease severity. Several are opportunistic pathogens emerging especially in hospital settings and immunocompromised patients. So, increasing antibiotic resistance poses a global challenge. Vaccines measures are key in prevention. Thus, understanding their morphology, virulence factors, pathogenesis, clinical features, diagnosis, treatment, and prevention is essential for both clinician and microbiologists. So we'll start with gram-positive cocci. Here, this slide introduces the broad group of gram-positive cocci. They are spherical in shape, spherical bacteria that stain purple on gram stain because of their thick peptidoglycan cell wall. They do not form spores. A key differentiating test is catalase production. So, Staphylococcus species are catalase positive, while Streptococcus and Enterococcus are catalase negative. Their arrangement also helps in identification. Staphylococci appear in grape-like clusters. So their arrangement also helps in identification while streptococci and enterococci occurs in chain. So the presence or absence of catalase, an enzyme that converts hydrogen peroxide into water and oxygen, is used to subdivide the various genera of the species. Staphylococci are gram-positive spherical bacteria that form grape-like structures. They are non-motile, non-spore-forming, and facultative anaerobes. They are catalase positive and grow easily on many types of media. Staphylococci are widely distributed in the environment, that is, air, water, and dust, and colonize humans and animals as well. They are subdivided into coagulase positive species, which is mainly Staphylococcus aureus, and coagulase negative species, which is Staphylococcus epidermis. As you can see here, coagulase positive is Staphylococci and coagulase negative is Staphylococci epidermis. Staphylococcus aureus is a common commensal colonizing the anterior nares, throat, skin, folds, and mucosa of about one third of the global population. It also colonizes warm blood animals and dairy livestock, which can shed bacteria into milk. Infections usually occur when epithelial barriers are breached by trauma, surgery, or viral infections. So, food poisoning results from ingestion of preformed heat-stable enterotoxins. S. aureus. The pathogenicity of S. aureus is linked to its ability to evade host defenses and produce a wide array of virulence factors. This includes surface structures that aid in adherence and immune evasions, toxins that damage host tissues, and enzymes that promote its spreading. Collectively, these mechanisms enable S. aureus to cause a wide variety of diseases. As you can see, pathogenicity depends on the ability of bacteria to evade its phagocytosis or produce surface proteins that mediate adherence of the bacteria to host tissue, as well as elaboration of specific toxins and hydrolytic enzymes. Cell surface factors of S. aureus, capsule and slime layer. It protects against phagocytosis and allow adherence to surfaces. As you can see here, bacteria will protect by inhibiting phagocytosis, and it facilitates slime layer adherence to foreign bodies. Next is SCRAMMS, which is nothing but microbial surface component recognizing adhesive matrix molecules. These proteins help bacteria attach to host tissues, evade immunity, and form biofilms. Examples include fibronectin binding proteins, clumping factors, protein A, and collagen binding protein. S. aureus toxin. So pore-forming toxin, which is cytolysin like alpha-hemolysin and leukotoxins, damage host cell membranes. And second is exfoliative toxins, which is EDTA, ETB, and ETD, which will degrade cell junctions, causing skin blistering. Example is scalded skin syndromes. C is super antigen toxin. So that is TSS1 enterotoxins include massive T cell activation, cytokine release, and shock syndrome. Next is secreted enzymes. So here CHIPS, CHIPS, that is chemotaxis inhibitory protein of Staphylococcus aureus. Here it will block neutrophil recruitment by binding to C5a receptors. Second is coagulase. It will convert fibrinogen to fibrin, forming clots that shield bacteria. Next is staphylokinase. It will dissolve fibrin clots, enabling bacterial spread. These factors help S. aureus persist and spread in tissues. Diseases caused by Staphylococcus aureus. So, impetigo, first is impetigo, superficial infection with pus-filled vesicle that rupture to form honey-colored crust, as you can see here in this image. Next is, so it will localize cutaneous infection primarily on the face and limbs. It is characterized by pus-filled vesicle, as you can see here, on an erythematous base. Crusting occurs after the pustular ruptures, which will result in the characteristics of honey structure exudate. Next is bullous impetigo. Bullous impetigo, it is a blister caused by exfoliative toxins, often considered localized scaled skin syndrome. So next is folliculitis. Here, mild infection of hair follicles with small pustules, as you can see in this image. Folliculitis, this is called as furuncle, this is carbuncle. So next is furuncle, which is boils, deeper and painful nodules from extension of folliculitis. Next is carbuncles, which is multiple furuncles merging into a deeper infection, often with systemic symptoms like fever. In this infection, patients with folliculitis and furuncles have chills and fevers together. Next is bacteremia. Beyond skin infection, Staphylococcus aureus causes bacteremia and endocarditis, pneumonia, osteomyelitis, septic arthritis, bacterial conjunctivitis, scalded skin syndrome, staphylococcal toxic shock syndrome, and staphylococcal food poisoning. So these bacteremia and endocarditis, it will infect heart valves, these two. Pneumonia, often following viral infections, osteomyelitis and septic arthritis, conjunctivitis, most common bacterial cause, and here this scale syndrome, toxic shock syndrome, and food poisoning is due to the toxin productions. Laboratory diagnosis of SRS. Diagnosis: microscopy show gram-positive cocci in clusters. Cultures on blood agar plate from skin lesion aspirates. Treatment include superficial infections. It will resolve spontaneously. Penicillin-resistant beta-lactamase will be given, that is methicillin and oxacillin are used. But MRSA requires vancomycin. MRSA is nothing but methicillin-resistant S. aureus. Next is coagulase negative staphylococci, which is CONS. CONS are staphylococci that do not produce the enzyme coagulase. The most clinically important species include Staphylococcus epidermis, Staphylococcus saprophyticus, Staphylococcus lugdunensis, Staphylococcus hemolyticus. They are part of the normal flora of human skin and mucosal surfaces. Though relatively virulent, their ability to form a slime layer enables them to adhere to medical devices, that is, catheters, grafts, prosthetic valves, and joints and shunts. Infections usually occur in immunocompromised individuals or when foreign bodies are implanted in body. So, coagulase negative staphylococci associated endocarditis. It is significant cause of endocarditis, especially in prosthetic heart valves. Staphylococcus lugdunensis is most often associated with native valve endocarditis. Prosthetic valve infection occurs when organisms are introduced at the time of valve replacement. These infections can cause abscesses at the suture line, leading to valve separation and mechanical heart failure. The main species responsible are Staphylococcus epidermis, lugdunensis, and hemolyticus. CONS associated infections, apart from endocarditis, it can cause bacteremia, urinary tract infections, wound infections, and infections of shunts, grafts, and prosthetic devices. These infections are especially common in hospital settings, making this organism important nosocomial pathogen. So as you can see here, organism and diseases mentioned in this table, which is common Staphylococcus species and the disease it causes. First is Staphylococcus aureus. It will cause toxin-mediated disease, which is nothing but food poisoning, scale skin syndrome, and toxic shock syndrome, cutaneous carbuncles, folliculitis, furuncles, impetigo, and wound infection. Other bacteremia, endocarditis, pneumonia, empyema, osteomyelitis, and septic arthritis. These are the diseases which can be caused by Staphylococcus aureus species. Staphylococcus epidermidis, it can cause diseases such as bacteremia, endocarditis, surgical wounds, opportunistic infections of catheters, shunts, and prosthetic devices. Next is Staphylococcus lugdunensis, which will cause endocarditis. And last is Staphylococcus saprophyticus, which will cause urinary tract infections in patients, usually in hospital-acquired patients. Next is streptococci. Streptococci are gram-positive cocci that appear in chains or pairs, as you can see the microscopic images here. They are catalase negative, unlike staphylococci, and are facultative anaerobes. They ferment carbohydrates and required enriched media like blood agar for growth, blood or serum enriched media for isolation or growth of the species. The genus contains over 100 species and many are significant human pathogens. Classification of streptococci is complex because Three overlapping systems are used. First is serological properties, lensified grouping based on cell wall antigens from A to W. Second is hemolytic patterns, that is alpha, beta, and gamma hemolysis on blood agar. Third is biochemical properties, physiological and metabolic features. Understanding all three systems help differentiate medically important species. Next is streptococci. So here it lensified grouping. It was first developed by Rebecca Lensified in early 1933. This classified streptococci based on group specific cell wall antigens, mostly carbohydrates. These antigens are detected using immunological assays. This system is still widely used, especially for beta hemolytic streptococci for groups A, B, C, and G. These are the groups. So most streptococci possesses group specific cell wall antigens, most of which are carbohydrates. These antigen can be readily detected by immunologic assays as well. So as you can see in this table, there are groups A, B, C, F, and G. Representative species include Streptococci pyogenes, Streptococci anginus group, Agalacti, Galacti, Anginosus group, and Digalacti. So it will cause diseases such as pharyngitis, skin and soft tissue infections, bacteremia, rheumatic fever, acute glomerulonephritis, abscesses, and for group B, it will cause neonatal disease, endometritis, wound infection, UTI infection, bacteremia, pneumonia, skin and soft tissue infections. And for group C, it can cause acute glomerulonephritis as well as pharyngitis. And for group F and G, it will cause acute glomerulonephritis, pharyngitis as well as abscesses. Streptococci hemolytic patterns. So here streptococci are differentiated by their hemolysis on blood agar plate. Beta hemolytic streptococci, it will complete lysis of RBCs, clear zones, it will caused by streptolysin O and S. So complete lysis of RBCs you can see in beta hemolytic streptococci, that is it will form a clear zone around their colonies. It is due to the production of enzyme hemolysins called streptolysin O and S. Next is alpha hemolytic streptococci. It will incomplete lysis, greenish discoloration can be seen due to hydrogen peroxide H2O2 converting hemoglobin to biliverdin. So incomplete lysis of red blood cell can be seen in alpha hemolytic streptococci. It will form green zone around their colonies because due to H2O2 production by the bacteria oxidizes hemoglobin, which is red in color, to biliverdin, that is green in color. Last is gamma hemolysis, that means no lysis, which is non-hemolytic colonies. This classification is especially useful for rapid identification in labs. So for gamma hemolysis, no lysis will be seen. Streptococcus pyogenes. General characteristics of Streptococcus pyogenes. Group A Streptococcus are gram-positive cocci that forms chain. They grow best in enriched media and are facultative anaerobes. On blood agar, they form beta hemolytic colonies. They are highly pathogenic, causing pharyngitis, skin infection, and systemic diseases as well. Streptococcus pyogene physiology and structure. Key structural features here is group specific carbohydrate, that is lensified group A antigen, and next is capsule. So group A, group specific carbohydrate, here less around 10% of dry cell weight helps classification. It is used to classify group A streptococci and distinguish them from other streptococcal groups. Next is capsule. It is composed of hyaluronic acid identical to mammalian connective tissue, helping evade phagocytosis. Encapsulated strains are more likely to cause severe infections in capsule. So some strains of S. pyogenes have an outer hyaluronic acid capsule. Antigenically, it is indistinguishable from hyaluronic acid in mammalian connective tissue. It will protect the bacteria from phagocytic clearance, and it will help in encapsulated strains more likely to be responsible for serious systemic infections. You can see here in this diagram Streptococcus pyogenes. M protein is the major virulence factor classified into class 1 and 2. Both cause suppurative infections and glomerulonephritis, but class 1 is associated with rheumatic fever. M protein inactivates C3b, preventing opsonization. Antiphagocytic strains without M protein are non-pathogenic. Epidemiologic classification is based on EMM gene sequencing M protein gene. Streptococcus pyogenes. So important enzymes include hyaluronidase, that is spreading factor. So here actually it is subdivided into class 1 and class 2. Both classes can cause suppurative infections and glomerulonephritis. Streptococcus pyogenes with class 1 M protein cause rheumatic fever. M protein inactivates this C3b, preventing opsonization, which is antiphagocytic. Here, epidemiologic classification of S. pyogene is based on sequence analysis of this EMM gene that encodes the M protein. Here, strains of Streptococcus pyogenes that do not produce M protein are non-pathogenic in nature. So, Streptococcus pyogenes produce several important enzymes. First is hyaluronidase, which is spreading factor. It will degrade hyaluronic acid, aiding spread in tissues. Next is streptokinase, which is fibrinolysin. It activates plasminogen to plasmin, dissolving fibrin clots and aiding spread. Next is IgG degrading enzyme, that is protease. So it will cleave IgG heavy chain, preventing opsonization and complement activation. These enzymes facilitate tissue invasion as well as tissue immune evasions. So Streptococcus pyogenes produce several toxins. First is erythrogenic toxin. Superantigens, it is responsible for scarlet fever and rashes. It acts as a superantigen. Second is streptolysin O. Here, oxygen labile hemolysin, antigenic antibody to it, ASO, is useful in diagnosing rheumatic fever. Both these toxins are central to disease manifestation. Third is streptolysin S. It is oxygen stable hemolysin and it is non-antigenic. Next is pyogenic exotoxin A. Superantigens, it is the main cause of streptococcal toxic shock syndrome. Next is exotoxin B. Here protease causing tissue necrosis seen in necrotizing fasciitis, which is flesh-eating diseases. These toxins account for the severe toxigenic manifestation of Streptococcus pyogenes. So these 5 are important toxins. Next is Streptococcus pyogene, 3 types of diseases. First is pyogenic infections. Pyogenic infection, it is a direct bacterial invasion. Example can be pharyngitis and cellulitis. Next is toxigenic diseases. It is due to bacterial toxins. Example is scarlet fever and toxic shock syndrome. Third is immunologic diseases. Results from abnormal immune responses. Example, rheumatic fever, acute glomerulonephritis. So these 3 classification of diseases helps understand the different mechanisms by which the same organism causes varied clinical conditions. Streptococcal pharyngitis, strep throat infection. Strep throat is the most common illness caused by Streptococcus pyogenes. It appears 2 to 4 days after exposure to the pathogen. Sudden onset of sore throat, fever, malaise, and headache will happen. Pharynx is erythematous with tonsillar exudate. Tender cervical lymphadenopathy is common in streptococcal pharyngitis. If it is untreated, recovery occurs in 10 days, but complications like rheumatic fever may follow. Complications of pharyngitis. Untreated pharyngitis can spread to middle ear, that is otitis media, sinuses, that is sinusitis, mastoid bone, mastoiditis, meninges, which is meningitis. Thus, early treatment of pharyngitis is important to prevent spread to adjacent structures. Disease caused by Streptococcus pyogenes, scarlet fever. Scarlet fever is a complication of pharyngitis caused by erythrogenic toxin. Here it diffuses erythematous rash, begins on chest, spreads to extremities. Rash has a sandpaper-like texture. The tongue becomes red and bumpy, which is called as strawberry tongue. Disease is both a pharyngeal and systemic manifestation of group A streptococcus. As you can see in this picture, nose and tongue will become red. Children will and infants will get rashes on sandpaper like texture. Next is pyoderma, which is impetigo. A skin infection caused by Streptococcus pyogenes, which is similar in appearance to impetigo caused by Staphylococcus aureus. Lesions occur on exposed skin, which is face and limbs, begin as small vesicles and it will lead to progress to pustules and then it will rupture and later honey color crust will be seen. It is highly contagious and often seen in children in warm and humid environments. Next is erysipelas. So, erysipelas is an acute superficial infection of the dermis. It appears as a bright red, swollen, painful lesion with well demarcated borders, often affects the face or legs, accompanied by fever and systemic symptoms. It is distinct from cellulitis, which involves deeper tissues with more diffuse borders. Next is cellulitis. Cellulitis is an infection of the dermis and subcutaneous tissues. Lesions are painful, swollen, warm, red, and have irregular margins. Progression is rapid and can spread extensively. Unlike erysipelas, margins are not sharply defined. Both Streptococcus pyogenes and S. aureus can cause cellulitis. Next is necrotizing fasciitis. It is also called as flesh-eating disease, a severe deep tissue infection caused by Streptococcus pyogenes toxins, mainly exotoxin B. It is characterized by extensive destruction of muscles and fat. Here, rapid progression with high mortality will be seen. It requires immediate surgical debridement along with antibiotics, and it is considered a medical emergency as well. Next is toxic shock syndrome. It is caused by superantigen toxins such as pyogenic exotoxin A. It will lead to massive cytokine release and then lead to shock, multiple organ failure, high mortality, and often associated with necrotizing fasciitis or bacteremia. Here, mortality may reach up to 40% despite treatment. Next is streptococcal bacteremia. Streptococcal pyogenes can enter the bloodstream, particularly in patients with necrotizing fasciitis or STSS. It will cause systemic spread of infections. Bacteremia increase mortality significance. Blood cultures are often positive in severe invasive cases. Next is acute rheumatic fever. ARF, which is acute rheumatic fever, is a non-suppurative complication occurring about 2 weeks after untreated streptococcal pharyngitis. Symptoms include fever, migratory polyarthritis, and carditis. Heart involvement damages myocardium and endocardium, especially mitral and aortic valves. Recurrent streptococcal infection worsen valve damage. It is an autoimmune disease due to cross reaction of antibodies against streptococcal M proteins with human tissues. So, acute rheumatic fever pathogenesis due to molecular mimicry, antibodies against M protein cross react with cardiac, joint, and brain tissues. It is an autoimmune disease, not a direct bacterial invasion. Early treatment of strep throat with antibiotics prevent ASF. Important sequela, chronic rheumatic heart disease with valve deformities. Next is acute glomerulonephritis. AGN is another non-suppurative complication. It occurs after streptococcal skin or throat infection. It is characterized by inflammation of glomeruli, which is caused by edema, hypertension, hematuria, and proteinuria. Hematuria is nothing but blood in urine. It caused by immune complex deposition, antigen antibody complexes in kidneys with complement activation. It usually self-limiting but can cause long-term renal damages. Next is Streptococcus pyogenes. Laboratory diagnosis of Streptococcus pyogenes. Microscopy. Gram-positive cocci in chain, often with leukocyte, will be seen. Culture. Beta hemolytic colonies on blood agar or bacitracin sensitive will be seen. Antibody detection, which is anti-streptolysin O test, useful in confirming rheumatic fever or AGN. These methods help differentiate Streptococcus pyogenes from other streptococci. So for culture, S. pyogen is susceptible to bacitracin, beta hemolytic, antibody detection, ASO test. Treatment of S. pyogenes. Penicillin remains the drug of choice. Alternative is cephalosporin, macrolides for penicillin allergic patients. Prompt treatment of pharyngitis prevents non-supportive complications for ARF and AGN, which is um, acute glomerulonephritis. No vaccine is currently available due to antigenic diversity of M proteins. Next is Streptococcus agalactiae, which is group B Streptococcus. Streptococcus agalactiae is the only species with lensified group B antigen. Gram-positive cocci, it is in 0.6 to 1.2 μm, arranged in short chains in clinical specimens and long chains in culture. Colonies on enriched media are larger than S. pyogenes and show a narrow zone of beta hemolysis. GBS is especially important in neonates, pregnant women, and immunocompromised adults. Serologic markers of S. agalactiae. Here, group B cell wall, polysaccharide antigen. Second is 9 type specific capsular polysaccharides. These, as you can see here. Third is surface protein, the most common being the C antigen. These 3 markers are useful in epidemiology and vaccine development of Streptococcus agalactiae. Pathogenesis and immunity of agalactiae capsule. It inhibits phagocytosis until type-specific antibodies will develop. Infants are highly vulnerable if mothers lack protective antibodies. Maternal colonization increases risk of premature delivery and neonatal infection. Premature infants are at the greatest risk due to immature immunity. Epidemiology. A natural colonizer of the gastrointestinal and genitourinary tracts, Around 10 to 30% of pregnant women will carry GBS in the vagina. 60% of infants born to colonized mothers become colonized. Neonates acquire infection in utero during birth or postnatally. GBS is the leading cause of neonatal sepsis and meningitis in newborns. Clinical diseases, early onset neonatal diseases, it occurs within the first week of life, often within hours of birth. Presents as bacteremia, pneumonia, or meningitis. Infections is acquired in utero or drug delivery. High morbidity and mortality without prompt treatment. Late onset neonatal disease, it occurs between first week and third months of age, usually acquired from exogenous sources, that is mother, other infants or environment. Bacteremia with meningitis is the most common presentation. Here mortality is lower than early onset diseases, but neurological complications may persist. Next is clinical diseases. In adults, pregnant women's postpartum endometritis, wound infection, urinary tract infection. For non-pregnant adults, infections are seen mainly in elderly or immunocompromised patients. Manifestations include bacteremia, pneumonia, bone and joint infection, skin and soft tissue infections. Mortality is higher in immunocompromised patients. So clinical diseases, it is in both in pregnant women, infectious in men and non-pregnant women as well. For pregnant women, postpartum endometritis, wound infection, and this symptoms will be seen. For non-pregnant women, it is compared with pregnant women who acquires this GBS infection. Men and non-pregnant women with this infection are generally older or elderly people and have debilitary underlying condition. The most common presentation include all these symptoms because these patients have compromised immunity. Mortality is higher in this population. Laboratory diagnosis, culture, vaginal and rectal swabs grown on enriched media, PCR, rapid sensitive detection of GBS. Treatment and prevention include penicillin is the drug of choice, which is very common. Alternatives is cephalosporins or vancomycin in penicillin allergic patient. CDC recommends screening all pregnant women at 35 to 37 weeks gestation. Chemo prophylaxis IV for penicillin G or ampicillin given less than 4 hours before delivery for colonized or high risk mothers. This reduces neonatal disease significantly. Next is Streptococcus pneumococcus. It is gram-positive, lancet-shaped diplococci or short chains. Cells are oval with pointed ends. On blood agar, it will produce alpha hemolysis, which is green color discoloration, differentiated from viridian streptococci by being bile soluble and optokine sensitive. More than 94 serotypes are known. Virulence factors of Streptococcus pneumonia. First is polysaccharide capsules. Major virulence factor prevents phagocytosis. It will interfere with phagocytosis and favor invasiveness. It will elicit primarily a beta cell, that is T-independent response, and it is specific antibody to the capsule, opsonizes the organism and facilitates phagocytosis. Second is teichoic acid. It will activate complement and induces cytokines. Third is pneumolysine, cytotoxin that binds cholesterol in host membranes. It is forming pores. Next is IgA protease. It helps colonization of upper respiratory mucosa. Together, this will enable colonization, invasion, and immune evasion. Transmission of pneumonia. Humans are the only reservoir. It will colonizes the throat and nasopharynx, especially in children. It is not highly communicable but spread via respiratory secretion. Disease occurs when organisms spread from nasopharynx to the lungs, pneumonia. paranasal cyanosis, sinusitis, ears, otitis media, middle ear, meningitis, meningitis. So these are the transmission of Streptococcus pneumonia. Next is clinical diseases. Pneumonia, sudden fever, chills, cough, pleuritic chest pain, sputum is often rusty due to blood. Next is sinusitis and otitis media. It is very common in children. Third is bacteremia. It occurs in up to 30% of pneumonia cases and less than 80% of meningitis cases. Meningitis, it is high mortality and morbidity, especially in young children and elderly patients. Laboratory diagnosis of pneumonia, microscopy, gram-positive diplococci with capsules visible by negative staining or quelling reaction, which is capsule swelling with anti-sera. So polyvalent anti-capsular antibodies are mixed with this bacteria. The mixture is then examined microscopically. A greater refractiveness around bacteria is positive reaction for Streptococcus pneumonia. Bile solubility test, pneumococci. Pneumococci are lysed by bile. Optocin sensitivity test, growth inhibited by optocin, culture alpha hemolytic colonies on blood agar, and PCR rapid confirmation. So these are the laboratory diagnosis. Culture specimen includes sputum, blood, CSF fluid, etc. Alpha hemolytic colonies will be seen on blood agar plate. These colonies are bile soluble, that is, it is lysed by bile, inhibited by optocin and PCR rapid confirmation. Treatment and prevention. Treatment, severe infections, it will be given penicillin G, mild infection, penicillin V via oral. Alternatives include macrolides, vancomycin for resistant strains. Prevention, PCV 13, that is Prevnar 13 conjugate vaccine used in infants and immunocompromised adults. PPSV 23, that is Pneumovax 23 polysaccharide vaccine used in adults and elderly. Vaccination is the best strategy for prevention against pneumococci. Next is Viridian streptococci. Viridian streptococci are a diverse group of gram-positive cocci arranged in chains. They are mostly alpha hemolytic or non-hemolytic on blood agar. Unlike pneumonia, they are not bile soluble and are optocin resistant. The term viridens comes from viridis, which is green in Latin, due to the green pigment produced during alpha hemolysis. Over 30 species and subspecies are still known. They are normal commensal of the oropharynx, gastrointestinal tract, and genitourinary tract, but rarely found on skin. They are nutritionally fastidious and often require around 5 to 10% carbon dioxide for optimal growth. Important species include Streptococci salivarius, Streptococci mutans, Streptococci mitis, and Streptococci sanguis. These species can cause opportunistic infections when they gain access to the bloodstream. So on access to the bloodstream, these organisms are most frequent cause of subacute endocarditis, which is salivarius and mitis Streptococci. So how do the viridians get access to the bloodstream? Due to trauma during dental procedures or vigorous teeth cleaning or flossing. So normally harmless commensal may cause subacute bacterial endocarditis, especially after dental procedures or trauma to oral mucosa. These Streptococci mitis and salivarius are the most frequent species isolated from endocarditis patients. Streptococci mutans is strongly associated with dental caries due to acid production from sugar metabolism. Next is Enterococci. It is previously classified as group D Streptococci, now placed in the genus Enterococcus. Gram-positive, it is gram-positive cocci, often in pairs or short chains. It will be seen. Facultative anaerobes capable of growth in extreme condition, that is 10 to 45 degrees Celsius, high NaCl concentration as well as bile salts. So it will form large colonies that appear non-hemolytic, alpha-hemolytic or rarely beta-hemolytic on blood agar. It can grow in high concentration of NaCl, a high temperature and bisalt as well, and differentiated by resistance and growth in 40% in bile. pH is around 9.6 or 6.5% salt solution. Enterococci in early 1984, they were reclassified into the genus Enterococcus. There are 38 species, but only a few are significant human pathogen, that is Enterococcus faecalis, Enterococcus faecium, Enterococcus gallinarum, Enterococcus cassili-flavus. Most infections emerge from patient's bacterial flora, part of the normal intestinal and urinary flora. Infections usually arise endogenously from the patient's own flora. Patients at risk include those who are hospitalized for prolonged or long periods of time on broad spectrum antibiotics, especially cephalosporins, to which enterococci are naturally resistant. Disease. Important cause of nosocomial infection disease included urinary tract infections, wound infections, especially intra-abdominal bacteremia leading to endocarditis. These are the common cause of subacute endocarditis, especially in hospitalized patients. Gram-positive spore-forming rods. Two medically important genus of gram-positive spore-forming bacilli. First is Bacillus, which is aerobic. Second is Clostridium, which is anaerobic. They are ubiquitous in the environment and form spores, allowing survival for years. Important pathogens is Bacillus anthracis and Bacillus cereus, Clostridium perfringens, Clostridium tetani, Clostridium botulinum, and Clostridium difficile. So, introduction. Bacillus anthracis causes anthrax, which occurs in three forms, which is introduction. These gram-positive spore-forming bacilli consist of Bacillus and Clostridium species. As I mentioned, they are ubiquitous, which means present everywhere in environment. Because they form spores, they can survive in the environment for many years. These species are aerobes. Clostridia are anaerobes. Medically important species include anthracis and Bacillus cereus. For Clostridium, perfringens, tetani, botulinum, and difficile. Bacillus anthracis causes anthrax, which occurs in three forms, which is cutaneous anthrax, which means via inoculation, inhalational anthrax via inhalation of spores, gastrointestinal anthrax via ingestion of contaminated food. Anthrax is primarily a disease of herbivores, but humans can become infected through contact with contaminated soil, animal, or animal products. Bacillus anthracis, its morphology and virulence factors. It is large gram-positive rods arranged in singly or in pairs or long chains. Virulent strains carry plasmid PX01 encoding 3 toxins, which is protective antigen PA, edema factor EF, and lethal factor LF. So toxin acts in combinations. PA plus EF, which is edema toxin. PA is nothing but protective antigen. EF is edema factor. PA plus LF leads to lethal toxin, that is protective antigen plus lethal factor. Virulence factor, capsule, it inhibits phagocytosis, and edema toxin, it will increase CAMP causing edema observed in anthrax by increasing the intracellular CAMP. Lethal toxin, It induces cell lysis and death. Spore enters via skin, inhalation, or ingestion, germinate in tissue, and spread via lymphatics and bloodstream. Pathogenesis. Anthrax is primarily a disease of herbivores, that is, goats, sheep, cattle, and horses. Soil is contaminated with anthrax spores from the carcasses of dead animals. Humans become infected through exposure to contaminated soil, animals, infected animal products such as hides, goat hair, and wool. Human anthrax. Human anthrax is acquired by one of the following routes, which is cutaneous anthrax. It begins as a painless papule, then later it becomes ulcer with vesicle and lead to necrotic eschar. It is untreated mortality, which is 20%. Gastrointestinal anthrax, it will cause mouth or intestinal ulcers, severe systemic illness, mortality up to 100%. Inhalation anthrax, biphasic illness, initial flu-like symptoms, sudden worsening with respiratory distress, mediastinal lymphadenopathy, shock, often fatal within 3 days if untreated. So, infections in human result from this inoculation and ingestion. Anthrax is very rare in humans, but ingestion is a common route of infection in herbivores. Pathogenesis. These spores germinate in the tissue at the site of entry, and growth of the vegetative organism will result in the formation of gelatinous edema and congestion. It is spread via lymphatics to the bloodstream. Clinical features. This cutaneous anthrax starts with the development of painless papule at site of infection, inoculation, and then rapidly progress to an ulcer surrounded by vesicle and then to necrotic eschar. Mortality is untreated. If it is untreated, then 20%. Gastrointestinal tract, it causes mouth or intestinal ulcers, severe systemic illness. If organism evades the cecum or terminal ileum, mortality is up to 100%. Inhalation anthrax, biphasic illness, initial flu-like symptoms, sudden worsening with respiratory distress, often fatal within 3 days if it is untreated. Laboratory diagnosis and treatment, microscopy, gram-positive rods, capsule visible with Indian ink, culture, non-hemolytic colonies on blood agar, non-motile, PCR for rapid confirmation. Treatment, penicillin, doxycycline, ciprofloxacin. Prevention is animal vaccination, safe disposal of carcasses, and human vaccine for at-risk groups, example, military, laboratory staff, etc. Next is Bacillus cereus. Bacillus cereus has lower virulence than Bacillus anthracis, but it is significant cause of foodborne illness. It produces two endotoxin. First is heat stable enterotoxin and heat labile enterotoxin. Heat stable causes emetic form, that is vomiting. Heat labile causes diarrheal form, which is watery diarrhea. Also produces enzyme toxin causing ocular infections and other opportunistic infections. Bacillus cereus and related species are ubiquitous in the environment, present in soil, dust, water, and food. Most infections originate from environmental contamination. Isolation from clinical specimen does not always indicate disease because many people are transiently colonized. So for food poisoning, two distinct forms of food poisoning: emit, that is vomiting form, second is diarrheal form. So emit form, it is caused by ingestion of preformed heat stable toxin associated with contaminated rice. So these two forms vomited, this is emetic form and diarrheal form. Emetic form is vomiting, usually result from consumption of contaminated rice. Intoxication caused by ingestion of heat stable enterotoxin, but not the bacteria. Incubation period for this is short, up to 1 to 6 hours, and duration of illness is less than also short, less than 24 hours. Symptom consist of vomiting, nausea, and abdominal cramp, fever and diarrhea. These symptoms are generally absent in emetic form. Diarrheal form caused by heat, labile toxin produced in the gut after ingestion of contaminated meat, vegetables, or sausages. So it is a true infection resulting from ingestion of bacteria contaminated with these sources. The organisms multiplies in the patient's intestinal tract and release of heat, labile enterotoxin follows. Enterotoxin is responsible for this diarrhea, nausea, abdominal cramp that develop, and it will last till 1 day or longer period of time in humans. Next is ocular infection. Ocular infection usually follows trauma with a soil contaminated object. It is rapidly progressive, involves the entire eye. It leads to complete eye loss within 48 hours if it is untreated. Extremely destructive due to multiple toxin and enzymes produced by Bacillus cereus. Other infections by Bacillus cereus in immunocompromised individuals, it may cause endocarditis, especially in for drug abusers, pneumonitis, bacteremia, meningitis, and severely immunosuppressed patients. These systemic infections are rare but severe. Laboratory diagnosis cultured similarly to Bacillus anthracis. Because colonization is common, implicated food must also be cultured for confirmation. Differentiation of emetic versus diarrheal form is based on clinical history and toxin type. Treatment: food poisoning, usually self-limiting, only symptomatic treatment is needed. Other infections treated with vancomycin, clindamycin, ciprofloxacin, or gentamicin. Here, Bacillus cereus is resistant to penicillin due to beta-lactamase production. Next is genus Clostridium. Clostridium, it is large gram-positive spore-forming anaerobic rods. Medically important species include Clostridium perfringens, Clostridium tatani, Clostridium botulinum, Clostridium difficile. It is found widely in soil, dust, sewage, and intestines of humans and animals. Clostridium perfringens, it is large rectangular non-motile rod. Spores are rarely seen in clinical samples. It is characterized by rapid spreading growth on agar plates resembling motility. 5 types include A, B, C, D, and E. Type A is most common or important in human disease, commonly found in intestine and soil. Pathogenesis of Clostridium perfringens infections are usually associated with wounds or trauma contaminated with spores. It produces multiple toxins and enzymes that cause lysis of cells, which is RBCs, platelets, leukocytes, tissue necrosis, and gas production, severe systemic effects, sepsis, massive hemolysis, and shock as well. Alpha toxins, it is a lecithinase that lyses RBCs, WBCs, platelets, and endothelial cells. Next is enterotoxin. It is produced during sporulation, causing food poisoning. Other toxins and enzymes contribute to tissue destruction in gas gangrene. So generally develops within a week after Clostridia are introduced into tissue by trauma or surgery. Onset is followed rapidly by extensive muscle necrosis, shock or renal failure, and even lead to death, often within 2 weeks of initial onset. It will produce large amounts of hydrogen and carbon dioxide gas, which is nothing but gas gangrene. Laboratory diagnosis: microscopy, large gram-positive rods in wound exudates. Culture: rapid growth under anaerobic conditions. Gas and toxin production confirm the diagnosis. Differentiated from other Clostridia by lack of motility and unique toxin profile. Treatment is gas gangrenes require immediate surgical debridement and high-dose penicillin G. Hyperbaric oxygen therapy may help. Food poisoning self-limiting results in less than 24 hours. Only supportive care is needed. Next is Clostridium tetani. Clostridium tetani is large motile spore forming rod. It produces round terminal spores giving a drumstick appearance. It is very sensitive to oxygen, making it difficult to grow in lab. Despite oxygen sensitivity, spores survive in soil for long period of time. Its epidemiology, it is ubiquitous in soil and occasionally colonizes the gastrointestinal tract of animals and humans. Vegetative cells are oxygen sensitive, but spores are highly resistant. Infections usually follow contaminated wounds, burns, or umbilical infections in newborns, which is neonatal tetanus. Pathogenesis and immunity. Pathogenesis produces two toxins, which is tetanolysin, oxygen labile, hemolysin, which its role is unclear. Next is tetanospasmin, which is tetanus toxin, a heat labile neurotoxin. Tetanospasmin, it is produced at wound site, travels retrograde in nerves, and then reaches to CNS. It blocks the release of inhibitory neurotransmitters, which is glycine and GABA, and causes uncontrolled muscle contraction, which is spastic paralysis. Clinical features: lockjaw, rigid contraction of jaw muscles preventing mouth opening, opisthotonus. These are arcing of back due to strong contraction of back muscle. Generalized tetanus may lead to spasm severe enough to cause fractures. Death often occurs from respiratory failure due to diaphragm and chest muscle spasm. Key difference from botulism is tetanus, spastic paralysis, botulism, flaccid paralysis. Laboratory diagnosis include clinical based on history of wound plus muscle spasm. Treatment include wound debridement, antibiotic, penicillin or metronidazole, passive immunization with human tetanus immunoglobulin, supportive care, that is muscle relaxants, ventilatory support. Prevention include immunization with tetanus toxoid. Next is Clostridium botulinum. It is large spore-forming anaerobic rods. Spores commonly found in soil and water. It will contaminate vegetables, meats, and canned foods. If sterilization is inadequate, spores germinate under aerobic conditions and produce botulinum toxin. Cooking food properly can destroy these toxins. Its pathogenicity, botulinum toxin, one of the most potent toxin known. Its mechanism is absorbed from gut and it reaches to neuromuscular junction. It will block release of acetylcholine at motor and plates and result in flaccid paralysis, that is muscles cannot contract. There are 8 immunologic toxin types, which is A till E, A till H, but A, B, and E are the most common and important in human illness. Clinical findings: forms of disease is foodborne infant botulinism and wound botulinism. For foodborne botulinism, ingestion of preformed toxin is improperly canned or preserved food. Symptoms include diplopia, dysphagia, dysphonia, and descending flaccid paralysis. Death may result from respiratory failure. For infant botulinism, infants ingest spores, which is commonly from honey. Spores germinate in intestine that leads to toxin produced in vivo. Symptoms include constipation, weak cry, flaccid paralysis, that is floppy baby. Third is wound botulinism. Spores contaminate wound that will germinate and produce toxin. Laboratory diagnosis of botulism, clinical suspicion is most important. Detection of toxin in food, serum, or stool using bioassays or immunological methods. Culture may confirm botulinum in wound or stool but toxin detection is crucial here. Its properties It is anaerobic spore-forming gram-positive rod. Organisms grow rapidly in culture, although vegetative cells die rapidly when exposed to oxygen. If it produces a variety of volatile fatty acids that produce a characteristic barnyard smell in culture, and it causes antibiotic-associated pseudomembranous colitis. Clostridium difficile is the most common nosocomial cause of diarrhea. Epidemiology and transmission. Part of normal flora is less than 3% of healthy adults and up to 30% of hospitalized patients. It is spread by fecal oral route. Most cases are hospital acquired, but one third are community acquired. Transmission is via hands of healthcare workers is significant. Pathogenesis antibiotics is clindamycin, cephalosporins, ampicillin. It will suppress normal gut flora, which helps Clostridium difficile overgrow. It produces two major exotoxin, toxin A and toxin B. Toxin A is enterotoxin, which attracts neutrophil, increases intestinal permeability, that is diarrhea. And toxin B is cytotoxin, depolymerizes actin and destroys cytoskeleton of intestinal cell. So these will result in colonic damage and formation of pseudomembranes. Clinical finding: pseudomembranous colitis, it is yellow-white plaques on colonic mucosa, diarrhea, abdominal pain, fever. Neutrophils are often present in stool, rarely spread systemically, and severe cases may progress to toxic megalocornin and perforation. Laboratory diagnosis through stool culture, toxin detection, and PCR. Stool culture detects C. difficile, but colonization without disease is common. Toxin detection, ELISA for toxin A and B is diagnostic. PCR detects toxin gene with high sensitivity and specificity. Treatment: stop the offending antibiotic, that is clindamycin and cephalosporin. First line therapy, oral metronidazole or vancomycin will be given. Recurrent cases, fecal microbiota transplantation, supportive care with fluid and electrolytes. Prevention: this treatment and prevention include hand washing with soap. Alcohol-based sanitizers are less effective against spores. Next is gram-positive non-sporing rod, which is Corynebacterium diphtheria. It is gram-positive non-spore-forming pleomorphic bacillus. It is arranged in palisades or angular formations. It is metachromatic granules visible with special stains. That is, example is Albert's and Nisser's. It causes diphtheria, a toxin-mediated diseases. Its epidemiology: it is spread via respiratory droplets or direct contact. Humans are the only reservoir for this. Disease is most common in children but can affect adults in areas with low vaccination coverage. Asymptomatic carriers are important sources of infection. Pathogenesis and immunity. Disease caused primarily by diphtheria endotoxin and coded by a lysogenic bacteriophage. Toxin mechanism: inhibit protein synthesis by inactivating elongation factor 2, which is EF2. It results in cell death and necrosis at infection site. Local necrosis plus fibrin plus leukocyte, it results to pseudomembrane. Here, toxin also spreads systematically, damaging heart, nerves, and kidneys. Pathogenesis and immunity. So the host responds to C. diphtheria infection through local inflammation in the throat with a fibrinous exudate that forms the tough adherent gray pseudomembrane characteristic of disease. And second is through antibody that can neutralize exotoxin activity by blocking the interaction of binding domain with the receptors, thereby preventing entry into the cell. Clinical findings: The clinical presentation of diphtheria is determined by the site of infection, immune status of patient, virulence of organism, diphtheria toxin produced at the site of infection and disseminates through the blood to produce systemic signs of diphtheria. Respiratory diphtheria, sudden onset of sore throat, malaise, fever, thick gray-white pseudomembrane on tonsil, pharynx or larynx, and membrane is adherent. Attempt to remove it cause bleeding. Severe cases is airway obstruction, systemic effect, myocarditis, erythromitis, and neuropathies. Clinical findings: cutaneous diphtheria acquired through skin contact with infected person. Organism colonizes the skin and gain entry into subcutaneous tissue through breaks in the skin, and papule will develop first and then evolves into chronic non-healing ulcer. Sometimes it will cover with a grayish membrane. Laboratory diagnosis is through microscopy, culture, ELIX test, and PCR. Microscopy, pleomorphic gram-positive rods with metachromatic granules. For cultures, selective media, that is Loeffler's medium, Loeffler's serum slope, telluride, agar will be used. And for ELIX test, it detects diphtheria, toxin production in vitro, immunodeficient test. And for PCR, it will confirm presence of toxin gene. Next is myobacteria. Myobacteria possesses a complex lipid-rich cell wall that is responsible for many of its characteristic properties. It is acid fastness, slow growth, resistant to detergents and common antibacterial antibiotics, and the host immune response is an antigenicity. Next is Mycobacterium tuberculosis. Mycobacterium tuberculosis, these mycobacteria other than Mycobacterial tuberculosis are complex and leprae. It is found in soil, water, and not usually transmitted through person to person. Opportunistic pathogens, especially in immunocompromised individuals. So for this, it has doubling time of 18 hours because growth is so slow. Cultures of clinical specimen must be held for up to 6 to 8 weeks before being recorded as negative. Mycobacterium tuberculosis is weakly gram-positive, strongly acid-fast rods. It is an obligate aerobe and causing disease in highly oxygenated tissues as the upper lobe of lung and kidney. This acid-fast property of tuberculosis is attributed to long-chain fatty acid called mycolic acid in the cell wall, and cod factor is correlated with virulence of these organisms. Transmission and epidemiology. It is transmitted from person to person by respiratory aerosol. The source of organism is a cavity in lung that has eroded into bronchi. Portal of entry is the respiratory tract. Initial state of infection is the lung. In tissue, it resides within reticuloendothelial cell. Example is macrophages. Humans are the natural reservoir of Mycobacterium tuberculosis. Although some animals such as cattle can be infected, but they are not the main reservoirs for human infection. In developing countries, Mycobacterium bovis also causes tuberculosis in human. It is found in cow's milk, which, unless pasteurized, and cause gastrointestinal tuberculosis in humans. Transmission and epidemiology occurs only a small number of infected individuals. Greater population at risk for disease are immunocompromised or patients having underlying health issues, patients consuming drugs or alcohol abusers, homeless person, and individual exposed to disease patients. WHO estimated that 1/4 of the world's population is infected with Mycobacterium tuberculosis. In 2019, it is estimated that 10 million people will fall ill because of tuberculosis worldwide. So a total of 1.4 million people died from tuberculosis. It is an intracellular pathogen. It is able to establish lifelong infection. At the time of exposure, it enters the respiratory airways and few of them will penetrate to the alveoli or bronchi, where they are phagocyzed by alveolar macrophages. And then Mycobacterium tuberculosis prevents fusion of phagosomes with lysosomes. It survives and multiplies within a cellular vacuole called phagosome. The organisms will produce a protein called exported repetitive protein. It prevents phagosomes from fusing with lysosomes, and this bacterium allows the organism to escape the degradative enzymes in the lysosome as well. Clinical diseases, although tuberculosis can involve any organ, most infection is seen in immunocompromised patients, which is restricted to the lungs. The patient's cellular immunity is activated and mycobacterial replication ceases in most patients within 3 to 6 weeks of exposure to the organism. Approximately 5% of patients well exposed to tuberculosis having active disease within 2 years. 5 to 10% will experience disease sometimes later in life, as their immunity is strong enough to cure with this infection. The likelihood that infection will progress active disease is a function both infectious dose and patient's immune competence. Pulmonary tuberculosis, patients typically have non-specific complaints of malaise, weight loss, cough, and night sweats. Sputum may be scanty or bloody and purulent. Extra pulmonary tuberculosis occur as the result of hematogenous spread of bacilli during the initial phase of multiplication. Diagnosis will be skin test and interferon release test, sensitive markers for exposure to the organism, microscopy, culture, and PCR microscopy through acid-fast staining. Culture, it will take longer period of time. Identification is most commonly made using specific molecular probes, sequencing, or mass spectrometry. Treatment, prevention, and control. Prolonged treatment with multiple drug of choice is required to prevent development of drug-resistant strain. Control of disease through active surveillance, prophylactic and therapeutic intervention, and careful case of monitoring. Anaerobic gram-positive rods is actinomycetes, which is chronic and slowly developing infections, lactobacillus, cutibacterium, and propionibacterium. Last is Mycobacterium leprae, which is Hansen's disease. It is first identified by Norwegian physician Armor Hansen in early 1873. It is found in soil and water, not usually transmitted this person to person. It is opportunistic pathogen, especially in immunocompromised individual. Important species is MAC, which is M. avium intracellulare complex, causes disseminated infection in AIDS patient. Cancei causes pulmonary TB-like disease, and Mycobacterium marnicum, which will cause skin infections. Leprosy, it is chronic infection disease caused by Mycobacterium leprae. It mainly affects the skin and nerves. Progressions will slowly with an average incubation period of 3 years. It will affect all ages and both individuals, male as well as female. Leprosy is also endemic in armadillosis. It can be cured. Multi-drug therapy kills the bacteria and stops the spread of this disease. If it is detected early and treated with MDT, that is multi-drug therapy, leprosy will not lead to disabilities. Epidemiology and transmission. Leprosy transmission is not entirely understood. Leprae is not very virulent. Most people will get affected with leprosy and are non-infectious. Here, bacilli remain within the infected cell. Multibacillary patients, however, excrete leprae from their nasal mucosa and skin. It is a long-term exposure of respiratory system to airborne droplets, main route of infection. Close and repeated contact with this patient is also a source of transmission. Primarily, Mycobacterium leprae primarily infects histiocyte, that is tissue macrophages and dermitis, Schwann cells in the peripheral nerves. Once it penetrates a cell, it will replicate, proceeds slowly until T cell recognizes mycobacterial antigens and a chronic inflammatory reaction. begins. The outcome of this infection and clinical manifestation depend on cellular immunity of the host. This Mycobacterium leprae escape macrophage killing by inhibiting phagosome-lysosome fusion. So clinical features and laboratory diagnosis. Clinical features is through skin smear. This skin smear has specificity of 100% and sensitivity of 50%. It is needed to confirm a clinical diagnosis of multibacillary leprosy. Specimen will be taken from the edge of leprosy lesion, nasal mucosa, and an earlobe. For detailed, PCR is highly specific and sensitive method, although it is quite expensive. Summary for gram-positive cocci. Staphylococcus aureus, it is pyogenic infection, toxin-mediated diseases. MRSA is also included. Coagulase negative staphylococci, that is CONS. It is opportunistic device-associated infection. Streptococcus pyogenes include pharyngitis, scarlet fever, necrotizing fasciitis, rheumatic fever, glomerulonephritis, and Streptococcus agalactiae, which is neonatal sepsis and meningitis. This will also include pneumonia, meningitis, and otitis media, which is middle ear. Viridian streptococci, endocarditis, and dental caries. Enterococci include E. faecalis and E. faecium, which is nosocomial infections, urinary tract infection, and endocarditis. Gram-positive spore-forming rods include Bacillus species and Clostridium species. For Bacillus anthrax is there, which is cutaneous, inhalational, and gastrointestinal. For Bacillus cereus, food poisoning, that is of two types, emetic, which is vomiting, and diarrheal, which is cause diarrheal food poisoning. Ocular infections, Clostridium perfringens, gas gangrene, and food poisoning. Tetani cause tetanus, that is spastic paralysis. Botulinum, botulinism, which is flaccid paralysis. Difficile, that is pseudomembranous colitis, antibiotic associated. For non-spore forming rods, Corneum bacterium diphtheria, pseudomembrane systemic toxin effects. Acid-fast bacilli, Mycobacterium tuberculosis of primary and secondary TB, pathogenesis, and MDR TB. Atypical mycobacteria include this opportunistic infections. Questions for 3 marks. Define gram-positive bacteria and give 2 examples of each. Second, what is the role of M protein in Streptococcus pyogenes? Third, name 2 toxin-mediated diseases caused by Staphylococcus aureus. Fourth, what is the quelling reaction and which organism does it identify? Fifth, list 2 differences between erysipelas and cellulitis. Sixth, what is the function of diphtheria toxin? Seventh, mention 2 complications of untreated streptococcal pharyngitis. 8. What are the first line of drugs for tuberculosis? 9. Name the 2 toxin of Clostridium difficile. And last, give 2 clinical differences between tetanus and botulinism. Questions for 5 marks. Discuss the virulence factors of Staphylococcus aureus and their role in diseases. Describe the pathogenesis and complication of Streptococcus pyogenes infections. Explain the clinical features and prevention of pneumococcal infections. Differentiate between early onset and late onset neonatal disease caused by Streptococcus agalactiae. Write short notes on gas gangrene, causative organism, its pathogenesis, and treatment as well. Describe the pathogenesis and clinical features of anthrax. Discuss the laboratory diagnosis and management of diphtheria. Explain the clinical features, diagnosis, and treatment of pseudomembranous colitis. Describe primary and secondary tuberculosis with pathogenesis. And last, write short notes on atypical mycobacteria and their clinical importance. So with this, we'll cover whole gram-positive part. Gram-negative part is pending. We'll cover that in next class.
Very stressful presentation, madam.
No issues, sir. This topic is quite lengthy
Finally,
only.
gram negative, I think you have gram positive you have completed today.
Yes, sir.
So
Gram
next
positive is
gram
completed
negative. Yeah,
for
yeah.
today's class. Next class, I'll start with the gram negative, sir.
Yeah.
All
So,
right, sir.
madam, will you plan for some MLT con or something like this?
What, sir?
MLT Con, MLT.
MLT. Yes, sir.
MLT Con, like CME or something seminar like program at our
No,
institute.
I never did that, sir.
Uh-huh.
Presentations and all I have done, but
Uh-huh.
seminars I have attended, but I have not presented there.
No, now you can present, no?
Sure, sir.
Uh,
I'll do.
One topic, whatever you like, you just suggest. Yeah, you can send me.
Yes, sir.
So what I'm thinking, no,
Mm-hmm.
yours and as well as one more Rafia Nida, yeah, Nida Rafia, and
Okay.
she has completed MSc MLT in biochemistry,
All
and now
right.
I think she is pursuing PhD in medical biochemistry. So we
Okay.
can take her, and you are there, and Aisha, one more. I think she also did MSc MLT medical
MSc.
microbiology. Yeah,
Mm-hmm.
medical,
Yes.
sorry, microbiology.
Yes, sir.
So we can have one some CMA like thing, no? Like
Sure, sir.
MLT con. Yeah. So one date we can decide
Mm-hmm.
so that we can have such a program at
Programs.
Shifa Hospital, yeah, Shifa Institute of Allied Health Sciences. So it
Mm-hmm.
will be benefit, I think, most of MLT students.
Students. Yes, sir.
So that's what. So you think of, madam, how
All
we
right,
can
sir.
proceed further, no?
Sure, sir.
So that one topic which is better and best for you, you can
Mm-hmm.
select, and you are the best speaker, so you can
Mm-hmm.
speak
Oh,
on
okay, sir.
that's okay.
Sure, sir.
Yeah, madam. Yeah, yeah. Please, thank you, madam. Thank you so
Thank you,
much, madam.
sir. Thank you
Thank
so
you so
much.
much.